Good morning and welcome to the GW Epilepsy Grand Rounds. Please wait until the last slide today for a code that you can text for CME if needed. Today I am delighted to introduce Dr. Jason Gerrard, who is Assistant Professor of Neurosurgery and Neuroscience at Yale. Jason earned his MD and PhD from University of Arizona, where his PhD work with Professor Carol Barnes focused on memory consolidation, formation and consolidation with aging. He later pursued his neurosurgery residency at Mass General, Harvard Medical School, followed by epilepsy surgery fellowship at Yale. Jason is now the president of Innovative Neuroscience, the president of the Society of Innovative Neuroscience in neurosurgery. At Yale, he heads the neural network and epilepsy and memory lab, and he's director of functional neurosurgery. His work has focused on utilizing systems approach to understand the neural networks in neurological disorders such as epilepsy and to design intelligent neuromodulatory interventions. And today's talk will be about neural networks in epilepsy and the evolving role of surgery. Dr. Gerrard.
That better? Yes, thank you very much, Dr. Kabisi, for the introduction and for the opportunity to be here today to speak. I'm going to spend most of the lecture talking about the evidence that's been mounting over the decades for epilepsy as a neural network disorder and how we need to adjust the approach that we take in epilepsy surgery for this mounting evidence and begin to approach epilepsy rather than a find the focus and take out the focus approach to a understanding the neural networks of epilepsy and how do we interact with those networks to try to prevent both epileptogenesis as well as seizure genesis. There are some announcements at the beginning of the talk, upcoming events. As far as the disclosure slide goes, I am a consultant with Medtronic, so I get some fees for mostly education and teaching consultation fees, and I will be discussing off-label use of medical devices during this lecture today. Here are the two learning objectives for the talk this morning and the information about the CME credit. There'll be additional slides at the end of the talk with instructions for how to obtain CME credit. So the general outline for my talk today will go through the focus quest, which has gone on for many decades, and then the mounting evidence that we have now for epilepsy as a network disorder rather than as a disorder of a focal substrate. We'll talk about our surgical failures, which are teaching us about epilepsy, the evidence that we have from some of our patients. I'll also spend some time, probably not enough time, talking about neuropsychiatric comorbidities. It's very common in epilepsy, the neuropsychiatric comorbidities. And there's some very interesting similarities between the neuropsychiatric networks and the epilepsy networks that are coming to light. And we'll talk a little bit about some of the neuromodulation data that we have, which also contributes to this information. We'll use this to get to the present state of where the epilepsy surgery is today. We'll go at least at Yale and go over our surgical decision tree and then talk about where we need to go and the various projects that are going on at Yale to help us get there. So in order to know where you are, you always have to know where you've been. And of course, these are some clips taken from some very intelligent physicians in the past who've treated epilepsy. And you can see there's this theme of there seems to be a focus, that there's a group of patients and that they had this semiology or something about their epilepsy that signaled that there was a focus. Of course, many of these patients did have lesions, and so there was sometimes this focus, and we'll talk a little bit about the difference between patients with lesions and those without. Stereo EEG, although it's quite popular today, is not a brand new approach. There's actually in the 60s, stereo EEG was done with a series of depth electrodes, and Dr. Spencer, my mentor at Yale, used this approach starting in the 70s into the 80s at Yale, and this is a picture of some of the electrodes that he would use back in the 1970s and 1980s. And then as the quest intensified, we had the development of the Spencer depth as well as grids and strips for surface electrodes, and we have all the different variety of electrodes that are used for your sort of basic intracranial monitoring today. Really hasn't changed a whole lot in general. There are a variety of different groups and a variety of different electrodes that individual groups will use for their research or for other purposes, but these are still pretty similar to how they are now. And of course, this story includes the medial temporal lobe epilepsy, which is one of neurosurgery's biggest success stories, if you will. I'm sure everybody's familiar with the randomized controlled trial in the New England Journal of Medicine showing the superiority of surgery over medical treatment in patients with medically refractory epilepsy. And the cure rate for patients who underwent successful anterior medial temporal lobectomy was quite good, on the order of 70 to 75%. Was a little bit lower in patients who had a history of generalized tonic-clonic seizures, but the vast majority of patients got a significant benefit from this surgery, and the morbidity rate was quite low if you go over the literature. And a lot of these patients, when the MRI era came into be, were found to have medial temporal sclerosis, or MTS. And that is now something we identify as a lesional epilepsy. And as time went by, these patients actually became less common, and patients without lesions became more common. This slide looks complex, but it's basically a list of epilepsy surgeries going back to 1983 at Yale, whether or not those patients had medial temporal sclerosis, whether or not they were neocortical. It's pretty well established at this point that neocortical onsets or onsets outside the temporal lobe, or especially the medial temporal lobe, can become much more complex than those patients with temporal lobe epilepsy. Their successful treatment rates are much lower. And so over time, these bars with the MTS patients were quite high, especially in the late 80s and early 90s, but ever since the mid-90s, this has been declining. And patients who are either non-lesional or have onsets outside of the medial temporal lobe are becoming more and more common. The other thing about the temporal lobectomy, which gives us some evidence of what's been going, of the fact that this is a network disorder, is as time went by, we began to realize that our long-term success rates weren't as good as the 1- and 2-year outcomes that were reported initially. And there's been some reports that it's about 50% when you get out to 10-year seizure freedom. And we'll talk a little bit about what the differences in failure rates, that being the early failure rates versus the long failure rates. And in extratemporal lobe epilepsy, we did even much worse. You get about half of those that fail will fail within the time period right after surgery, and then you have a much smaller failure rate, sort of annual failure rate in patients who fail outside this early time period. These patients who fail outside the early time period seem to be more easily treated with medication therapy. And so it suggests that there's two different groups of patients here. First of all, it provides us the first hint of evidence that their epilepsy is a network disorder, and the surgery is disrupting that network, but not necessarily getting the entire network. So there are connections outside of the medial temporal lobe structures that are removed during the surgery. And then it could be in this group of patients, there's still a strong connectivity to a node that's somewhere that wasn't taken out of part of the surgery. And in this group of patients, that sort of network is less robust, if you will, and it requires a period of time during which I would theorize that there's been additional epileptogenesis before the seizures recur. Some people would say that you miss the network here and these patients still have continued epileptogenesis, but my guess is that the difference is the robustness and the connectivity of the networks in these patients. So we're going to go through a variety of evidence, not all of it recent, some of it's been around for decades, that talks about the network the epilepsy is a network disorder. We already talked about the failure of complete control in medial temporal lobe epilepsy. Variable ictal onset in the local MTL circuits. Anybody who does intracranial studies with depth electrodes can tell you that if you have depth electrodes in the amygdala and the hippocampus, intermental cortex, that you can see a patient have 4 or 5 seizures. They all have the exact same semiology. They all look the same on the video. But when you look at the EEG, sometimes they start in the hippocampus, sometimes they start in the amygdala. And this was seen at Yale in the 90s. Dr. Dennis Spencer and Susan Spencer published these data in the 1990s showing that there were 9 patients with electrodes that were in the hippocampus, some in the amygdala, some in the intermental cortex, and patients would have the same exact behavioral seizure on video, but their ictal onset could be in any one of these structures independently, even though the semiology was exactly the same. And so this is when at Yale we began to think about the network approach of epilepsy, and we'll talk a little bit about some additional evidence that supports this as well. So sometimes seizures actually get cured or improved by removing one of the local nodes. So there are data out there that show that if you just take out the amygdala in a medial temporal lobe epilepsy patients, that about half of those patients will do well, the other half will not. And if you take out just the hippocampus, you can see the similar thing. It's something that I think we're rediscovering with the laser interstitial thermal ablation or LIT therapy, that sometimes if you just get the hippocampus, you get about a 50% cure rate, which is very similar to amygdalectomy series that were reported several years ago. We all have patients who do well after temporal lobectomy but continue to have auras. About 20 to 25% of patients who don't have seizures that alter their consciousness will still report auras, a focal seizure that doesn't interrupt consciousness. This again suggests that there's at least part of the epileptic network that remains after surgery. As I said, there is report in 1991 of 100 patients who had amygdalectomy and temporal lobe epilepsy, and they had a 50% response rate. More recently, you'll see people using laser interstitial thermal therapy, which we also provide at Yale, and you can take out parts of the medial temporal lobe, sometimes just the hippocampus, sometimes hippocampus and amygdala, and so far the 1-year seizure freedom rates seem to be about 50 to 60%, quite similar. Next, patients with bitemporal epilepsy could be controlled by removing the most dysfunctional hippocampus. That is, patients who had evidence in intracranial studies of bitemporal onsets of their temporal lobe epilepsy. The way that Dr. Spencer approached this was the hemisphere that showed the most dysfunction on neuropsychological testing. If that hemisphere was removed through temporal lobectomy, that again, about half these patients would have a cure and the other half the patients would not. So the evidence that sometimes you could take out a very important node in the network, and sometimes taking out that node in the network did not significantly alter the patient's epilepsy. Interestingly, another piece of evidence is that these patients had a much higher failure rate over the course of time than your standard MTS temporal lobectomy patients did. This is the paper published from the Yale series. It was a rather small number of patients. But you had this very, very good cure rate in patients about the order of the standard medial temporal lobectomy in this group of patients where the most sick appearing temporal lobe on neuropsychiatric testing was removed. But again, their long-term recurrence rate was higher than MTS patients. Our difficulty in dealing with epileptic regions outside the medial temporal lobe. We definitely do much worse in our therapy for patients who have epilepsy that starts outside the medial temporal lobe structures. And some of this is, in my opinion, because we don't understand the networks of the various cortical structures nearly as well as we have a good understanding of the medial temporal lobe structures, the Pepez circuit. We've all studied the particular connections in this particular circuit. But when it comes to epilepsy that patients have that's neocortical, that's based outside the medial temporal lobe, whether it's in temporal lobe cortex or frontal lobe cortex, we understand these networks, their connections much less so than we do in the medial temporal lobe networks. This, of course, is changing with the advent of functional MRI studies, and we have every day more and more information about the connectivity and the functional connectivity of various structures within this cortex. Finally, in our neuropsychiatric testing, we also have distributed deficits. I'm sure we've all seen this in epilepsy conference where you have patients who clearly have dominant hemisphere by fMRI testing onsets and their EEGs, but their neuropsychiatric profile shows weaknesses of their non-dominant hemisphere. And you can see this distribution of neuropsychological or cognitive function deficits across a variety of epilepsy patients. Next up is what's been called paradoxical MTLE. This is a description for the non-lesional temporal lobe epilepsy. So once medial temporal sclerosis was seen on imaging, it had of course already been documented on pathology, then it was obviously easily identifiable, but there were still many patients who clearly had temporal lobe onset who didn't have MTS. And this has been described as paradoxical MTLE. And when we look at these patients, their outcomes are not nearly as good. Their MRI is normal. They don't have MTS, but they undergo intracranial study that shows depth electrode onset of their seizures right in the hippocampus. Not all that different from the MTS patients. Their pathology is very different. They do not have the high amounts of cell loss in the hippocampus as MTS patients do. That their seizure control outcomes are inferior to the patients with MTS. It's, again, being now classified as lesional versus non-lesional epilepsy. Some other information that we have from some of the work that's been done at Yale as far as the network disorder comes from metabolomics and energetics. We'll talk a little bit about extracellular glutamate levels in epilepsy patients as well as in animal models. And the punchline in this data is that the glutamate levels in the extracellular space are higher in the epilepsy onset zone than they are in the baseline normal cortical areas. But they're even higher at seizure propagation nodes. That is, if we look at patients who have intracranial studies, that you see the elevated level of extracellular glutamate at the seizure onset zone, but you see even higher levels at the next connected nodes to that seizure onset zone. And a little bit about some 7T MR spectroscopy that was done at Yale by Julie Pan during her time there that shows that there's abnormal metabolic signals, not just in the hippocampus that we know is abnormal at the seizure onset site, but in the contralateral hippocampus as well, and then also in the thalamus as well. So again, well documented nodes in that network. And this is the data on the glutamate. So for about 25 years, Dr. Spencer has been utilizing depth electrodes that have membranes at the tip of the electrodes that allow us to do microdialysis. So in addition to recording EEG from the depth electrode, we're also sampling the extracellular space through this filter in the depth electrode, and that microdiastolate is brought into the system and stored in little vials, and you can get a sample about every 5 minutes. So that's its major drawback, is that your time frequency sampling rate is one sample every 5 minutes. But you can look at lots of substances that are in that extracellular space. And if we look at the hippocampus and the cortex, if you look at baseline levels, that is taken from depth electrodes that are placed in non-epileptic onset zones or even propagation zones. So depth electrodes taken from depth electrodes that aren't involved at all in the patient's seizures, and you compare this to depth electrodes that are involved in the epileptic onset zone, you see a significant difference in the extracellular glutamate levels. But what's interesting is if you go to the next propagated nodes, you see this even higher levels of glutamate, suggesting that there's a metabolic disturbance in that network, and that you have a network or a node that's downstream in the network that already has high glutamate levels, which is an excitatory neurotransmitter, and so it's sort of almost primed, if you will, for excitatory transmission. In addition, with the 7T MR, again, you can see metabolic disturbances through the different ratios that are shown here. In the hippocampus, that's not too surprising, in the hippocampus in the seizure onset zone. But what's more interesting is you can see very similar metabolic disturbances, which suggest abnormalities in mitochondrial processes that provide energetics for the cells, in the thalamus as well, in these patients who have medial temporal lobe epilepsy. I alluded in the beginning to our long-term surgical control as sort of the first idea that we weren't quite getting the whole story in this picture. This is just some data from other groups from the Cleveland Clinic that can verify this. Overall 33% long-term control. This is if you take all comers. If you break that out into whether it's lobar, multi-lobar, or sublobar, you can see the different outcomes, which can be down in a range of 20% in the long-term outcomes. This is out to 10 years here. We have a database at Yale that goes back several decades, and we've recently done a greater than 10-year outcome on all the patients who we followed for greater than 10 years. And we see something very similar to that last slide. So if we look at our patients who have classic temporal lobe epilepsy, who have MTS, you see this very good outcome scale, that patients even out to 10 years, even 20 years, you still are in a 60 to 70% seizure-free range. You see this initial failure rate, which has been described over and over again in a variety of papers, suggesting that in these particular patients there's a part of the network that still exists, or some epileptogenesis that happens quickly. But this gets pretty stable as time goes by. But if we start to look at other patients who aren't in that classic lesional temporal lobe epilepsy, then it starts to look very similar. You see failures start to pop up all over the place. And so we looked at what is it that predicts patients who are going to fail, who are more likely to fail in the long term versus those who do well. And a lot of it's things that everybody would have guessed. So if patients have discordance of their data, then their much higher failure rate drops to 50% within 5 years. Just undergoing intracranial EEG was the biggest predictor of long-term failure. And you say, oh, well, why would you have that long-term failure? That we do intracranial EEG to study these patients and figure out their epilepsy to treat them best. But if you think about it, patients who undergo intracranial EEG are always the patients who have discordant data, right? So the patients who have everything that lines up, they go straight to surgery. Remember, these are all temporal lobe epilepsy patients. So just undergoing an intracranial study drops your long-term seizure freedom rate down to about 50%. Of course, if you stop the medications, and then, and consistent with everything else we've already discussed, if you have non-lesional pathology, you're much more likely to fail in the long term than if you have a lesional pathology. But what we also found very interesting, and this is still in preparation, is that a very strong predictor of failure in the long term was the time it took for your seizure to spread. And again, this is evidence that this is a network disorder. And we're not talking here about spread from contact 4 to contact 5. We're talking discordant spread. In other words, spreading from this strip, which is along the medial and anterior aspect of the temporal lobe, and this grid, which is sitting on the lateral part of the cortical surface in the posterior lateral temporal lobe. So a spread from contact here to contact here isn't considered what we're describing as discordant spread in this slide, but a spread from here to here is. And if we looked at the time that spread took to occur, if it was under 10 seconds, it was a very strong predictor of worse seizure control. In fact, it was the strongest predictor of seizure control. If you have spread that's faster than 10 seconds to a non-continuous node in your intracranial study, you dropped to a 25% seizure freedom rate at 4, 5, 6 years out. If you had seizures, on the other hand, that stayed in the same area for a long period of time, then you had a very good outcome. You had greater than 75% chance of having long-term seizure control. So all of these things that we were learning from temporal lobe epilepsy were teaching us that we were dealing with a network disorder, and that we needed to start to think about epilepsy as a network disorder. There's a lot of data that's gathering every day, and we don't have time to talk about it in this slide, as I'm trying to focus on surgical techniques and where we need to be with surgery as we go forward into the future with treatment. there's a lot of neurophysiology data that's showing that it's not necessarily firing rates that change with seizures. It's not necessarily all just excitatory stimulation that's changing with seizures. What's changing in seizures is the synchrony across a variety of regions that shows that what's happening when someone has a seizure is that these networks are becoming too synchronous. And you have too many areas of the brain that are oscillating together. If you look at sort of normal EEG, if you will, normal awake EEG, you guys do that a lot more than I do. You know, you see a lot of, when you start to see things that look like they're slowed down or that they're oscillating together, that's not considered a good thing, right? You see slowing in the EEG. That's not the sort of standard way that awake behaving EEG looks like. And that's what we're seeing more and more with a lot of these intracranial studies with different variety of techniques, that it's not just a change in firing rate, it's a change in synchrony across networks. Another piece of evidence that this is a network disorder, and we have a Lancet Neurology review coming out next month that goes through all of this, is in the neuropsychiatric comorbidities. Everybody who treats epilepsy knows that the most common comorbidity in epilepsy are neuropsychiatric disorders. About 25 to 75% of epilepsy patients will have a comorbid psychiatric disorder. And if you compare epilepsy patients to non-epileptic controls, they have a 43% greater likelihood of having depression. Combine this fact with the explosion in fMRI analysis, the description of multiple cognitive networks in the functional imaging realm, as well as mathematical models such as mathematical graph theory that describes how to set up nodes in a mathematical study. And you have this huge growth in the study of functional networks. And there's been a big growth in the description of cognitive networks based on fMRI study, and this is just a list of few. The most well-published is the default mode network, a network that didn't exist, at least in the literature, until fMRI discovered this network, and now there's thousands of publications on the default mode network. It's reported to be the part of the brain that's active when you're not doing anything, when you're just sitting quietly. The patients just sit quietly in the scanner, and they're essentially told to close their eyes and just think about whatever they want. Attentional networks, so there's been a dorsal and ventral attentional networks described, reward emotional network, executive function network, etc. You can sort of understand the different connections that these are going to include. There's a great review that Rayner wrote in Epilepsy Currents last year that goes over a lot of these different areas that have been described in the functional imaging literature as far as their contributions to both neuropsychiatric disorders and epilepsy. And this is a combination of cognitive networks and depression and epilepsy. And you see a significant amount of overlap in the different structures that you'll talk about. A lot of structures in the frontal lobe, whether it's prefrontal cortex, both lateral and medial prefrontal cortex are involved in a variety of these networks. The precuneus is a big node in the default mode network. A lot of connections through the cingulate system in these networks as well. And so if we take a look at these fMRI networks that have been described, for instance, the most commonly described network is the default mode network. This is taken from a publication in Epilepsy in 2013, Cataldi et al. And if you look at the default mode network in controls versus epilepsy patients, you see significant changes in the connectivity of the network. So one of the things that's been repeatedly described is that the connection between the frontal node and the parietal node in this network on fMRI is reduced. So you see a decrease in the connectivity between the parietal nodes and the frontal lobes. You also see in epilepsy, patients with temporal lobe epilepsy, mind you, an increase in the connectivity between the nodes in the frontal lobe. So if we say, well, what happens in depression? Here's a paper. There's more than a couple, several papers out about the default mode network in depression. And if you compare depression patients to control subjects and look at their default mode network, again, you see a decreased overall connectivity within the parietal regions as well as a connectivity between the frontal and parietal nodes. So you see this same loss of connectivity between the parietal nodes of the network and the frontal nodes of the network in these neuropsychiatric disorders that we're seeing in epilepsy. And if you go through the major networks that have been reported in the fMRI literature, and you look at the default mode network, This is a table taken from our publication that's going to come out next month. You can see in several of these networks, of course, it's not all the data is not concordant, it never is, but you can find data that suggests that there's similar connectivity changes between patients with focal epilepsy and patients with neuropsychiatric disorders in these fMRI networks. And this happens in the dorsal attention network, in ventral attention network, in the executive control network, and in the reward emotional network as well, which of course involves the amygdala as well as connections to the frontal lobe. And you see these connectivity changes, whether it's an increase in connectivity or a decrease in connectivity, that overlap significantly with the neuropsychiatric disorders. So could it be that the reason that neuropsychiatric disorders are so high in epilepsy is not a coincidence, that maybe the epilepsy, the seizures themselves, are changing the way these networks are connected and changing the way that these networks interact with each other. And sometimes, or actually not all that uncommon, those connectivity changes or those functional changes in the network are leading to these neuropsychiatric disorders, so that the networks are overlapping. So that summarizes the data that I wanted to present as far as talking about the change in approach to epilepsy. Thinking about it not as we need to go find the focus and take it out, to we need to understand the network. And then rather than looking for the focus, because it's becoming increasingly apparent that even focal epilepsy probably isn't all that focal, and that many times it's actually a distributed network in focal epilepsy. But what we don't have, what we really need, we have this huge growth in fMRI studies and fMRI networks that I just talked a little bit about. There's a lot more out there that you can read about. But we don't have neurophysiological confirmation of these fMRI networks. These are all reported using the BOLD signal. There's probably many people in the room that know this much better than I do. But it's not the same as what we do in EEG, and the frequencies that you're studying are on orders of magnitude different. So in the fMRI, you have a very good spatial resolution, but what you don't have is good temporal resolution. And so we need neurophysiological confirmation of these networks. We need to understand how these epileptogenic networks are connected and how they create synchrony within the network and across the brain. You've all seen patients who go into generalized seizures where the cortex all gets into a very slow rhythm. How does that happen? Why is it that sometimes it just stays in the hippocampus and sometimes it doesn't, and then you get the entire cortical surface shut off? And intracranial studies remain the gold standard for acquiring this type of data. So when we look at the experience that we've had, the information that's been gathering out there, as well as the new surgical technology and techniques that have become available to us, this is the surgical decision tree that we utilize, which has been modified a lot in recent times as far as the new technologies. We'll talk a little bit about them, although I'm not going to focus too much on the new technologies. I'm going to be more discussing about how we can improve them to get where we need to be. So if you have this decision tree, patients have your sort of very typical epilepsy center non-invasive workup, and they essentially split out into patients who are very concordant, a singular lesion, they have a tumor, cavernoma, with full concordance of the perioperative workup. And then the next question, of course, becomes, is there functional cortex involved? If it's not involved, you can go straight to a resection. This is your sort of standard medial temporal lobectomy patient who has all concordant data. In certain patients, you can use ECOG for different types of cortical dysplasias or cortical malformations. And we've added now here laser ablation, which is, of course, a growing technology that's available to us now to utilize for minimally invasive resections. Functional cortex is involved. You can do functional mapping if you clearly have concordant, and then guided resection versus laser ablation versus RNS, responsive neurostimulation, for patients whose functional cortex overlaps significantly with their seizure onset zone. MTS, we've talked about, is essentially been lumped in with the lesional epilepsies, and then the question really just becomes function. If that hippocampus function is normal, at Yale, we will not resect a hippocampus that has normal memory function as far as if it's a dominant, especially if it's a dominant hemisphere, and their language verbal memory functions are not more than 2 standard deviations below the mean, they will get responsive neurostimulation. If their hippocampal function is not preserved, if it's already more than 2 standard deviations below the mean, or especially if it's a non-dominant, then they will get straight to resection. More and more we're seeing patients go down this arm. The MTS patients seem to be drying up. And these patients have either diffuse or multifocal lesions. They can have a normal MRI, they have non-lesional epilepsy, or they have a discordant preoperative workup. And you'll see what we call CEG, which is combined intracranial EEG. SEEG is very popular these days, so we continue to use DEPs. We've used DEPs for over 40 years at Yale, but we combine them in many cases with grids and strips as well. If patients have specific, such as tuberous sclerosis, FCD, specific malformations of cortical development, you can use intraoperative ECOG, but the majority of our patients go on now to intracranial study, and then depending on what you find in that intracranial study, there's a variety of surgical options available, whether it's resection, laser ablation, if functional cortex is not involved. When functional cortex is involved, then sometimes we'll do a limited resection, a limited laser ablation, or a disconnection process, such as multiple subpial transections, or responsive neurostimulation. And then if you have a multifocal or a network onset, where we're now starting to put the term network right into our surgical tree, then you have a variety of neuromodulatory options, which we've started to include laser ablation, because we're now utilizing, in some cases, laser ablation for disconnection therapies. Over the course of the last several decades, we've described in the literature, actually Susan Spencer published a paper on this in 2002, have shown over and over again, there's probably much more than this, but there are at least 3 widely seen networks in patients that have intracranial studies. And when we do these intracranial studies now, what we're doing is we're trying to cover a network. So when we design our intracranial studies, we're not just trying to put electrodes where we think the seizure onset is, but we're using electrodes to cover whatever part of whatever network they may be involved in. So we see the number of electrodes that we use rise. Now the most recent data is up to almost 250 electrode contacts on your average intracranial patient. This is just an example. This is only a unilateral study, but this patient still had almost 200 contacts. And these are just standard clinical contacts. We don't count all the experimental contacts that different places might use that are micro contacts or smaller contacts in these patients. So to illustrate this, I'd like to go over quickly just a case study of a 20-year-old gentleman who has medical intractatory epilepsy, began at age 8, has a very characteristic seizure. He describes a very recurrent semiology with confusion, limb stiffness, head nodding, very nocturnal. His seizures tended to be mostly at night. And he had undergone a extensive preoperative evaluation, which was non-lateralizing. He then underwent a survey study, which is a bilateral intracranial study, which had about 225 just macro electrode contacts. Again, we're approaching this as a network disorder. So when we do this, we are trying to study, in this particular patient's case, the data suggested he had a frontal parietal network onset. This is done through 2 small craniotomies on either side of midline, and you can slide these strips in that cover a large area of cortex. Also interhemispheric strips, which cover this region of the frontal parietal lobe, combination with depth electrodes to cover deeper structures, the cingulate, as well as the insula. He had 5 seizures during this study. They were all very typical for his epilepsy, and he had 2 onset zones. One was frontal, one was parietal. And sometimes these were simultaneous, sometimes one would lead the other, but there wasn't a clear indication from our recordings that one was the dominant onset zone. And when we look at a connectivity analysis of this patient's intracranial EEG, this is done during the intracranial times, you can see the strong connectivity using an analysis that each one of these contacts had a strong connectivity, usually either to the frontal or the parietal onset zone. This is the patient's dominant hemisphere overlapping with functional cortex. So he had responsive neurostimulation placed. These are the outlines here where the strips were placed. He had 4 strips placed. Only 2 can be plugged in. We'll talk a little bit about that. And he underwent long-term monitoring and treatment with his responsive neurostimulator. Unfortunately, he didn't get a lot of therapy from his responsive neurostimulation, so he eventually came back. And the reason that he came back is because with 3 years of recordings from his RNS device, the vast majority of his seizures were coming from this frontal node. Very few were coming from the parietal lobe, and so he underwent a medial frontal resection and was in seizure-free for 5 years. He discontinued his medications after 5 years, and his seizures returned within 3 months, which again suggests that even though we took out this big node in the network, there's still some network there, and without the medications, that network again is capable of seizing. So we're modulating this network, and what types of tools do we have to modulate the network now that we're approaching this with a different viewpoint? Well, most of these things have been, people have seen. Vagal nerve stimulator has been around for a long time. Deep brain stimulation is now approved in Europe and Canada, but it is not FDA approved in the United States. RNS, the NeuroPace system, the responsive neurostimulation, is FDA approved. And there's been seizure warning systems that have been out there for patients using intracranial data. Just to give you an idea of the present state of this technology, there's the responsive neurostimulation or NeuroPace device. You can put in standard depths or strips connected to a device that's implanted in the skull. And this is long-term ECOG data where you can see the different types of seizure triggers. When the detector goes off, it delivers stimulation for a brief period of time. Was FDA approved several years ago, and it has pretty good long-term. So 60% of patients have a 50% decrease in their seizure frequency. Interesting that if you go back to the surgical data, we often saw this 50% outcome in the outcomes data. Just an idea of the different detectors that can be set on these devices that detect seizure onset areas and stimulate. When you see the signal taken out, that's when the stimulation is on. And this is data taken from the pivotal study. At 24 months, you had the responder rate. So a responder is someone who has a greater than 50% reduction in their seizure frequency. And so you see this responder rate gradually improves over time, something that you'll see over and over again in the neuromodulation therapies. As I said, we'll back that up with showing some of the Sante trial long-term outcomes. So these patients underwent deep brain stimulation with electrodes placed in the anterior nucleus of the thalamus for treatment of their epilepsy. And again, you see this improvement. Here's 1 year, 2 years, out to 5 years. You see this gradual improvement over time. And I think that's because you're modulating this network, and that changes in the network require time. And so you see this improvement, very similar, 50 to 60%. When you get out to 5 years, you have a significant number of responders. The hardware that's used for this is implanted in the anterior nucleus of the thalamus. It's approved in Europe and in Canada, not approved in the US. So this therapy is utilized outside the US quite frequently at this point. And again, their 5 years have a 69% responder rate. Very few of these patients are cured as far as we talk about in the surgical data, but there is a significant response to these variety of modulatory approaches. The other surgical innovation we talked about is LIT, or laser interstitial thermal ablation, which is utilized for treatment of a variety of epilepsies. It can be used for periventricular nodules, utilized in medial temporal lobe epilepsy. And as I stated, we're utilizing as a way to disconnect brain structures. You'll see descriptions out there now being utilized for things like corpus callosotomy, where you can do the entire disconnection through 1-2.5 millimeter burr hole. It's definitely a nice tool to have to be able to do things with a minimally invasive approach. So as I said, our patient underwent an RNS device. And the main benefit that that device gave him wasn't the therapy it directly delivered. It was the long-term monitoring. And this is the key, and this is where we need to go. We need patients to not be in the epilepsy monitoring unit for 10 days, 20 days, 25 days in an artificial environment with thousands of wires coming out of their head while we're playing with their medications. We need to understand their seizures at home. We need them to go home. We need them to live their lives, and then we can understand their seizures. There's been a recent publication in dogs that showed that you don't actually record the usual seizure for that animal, and that there's changes in the spikes and the seizures over the first 6 months after that implant in those animals. So you really need long-term data. This is what delivered his eventual therapy that was very beneficial. And then once he self-discontinued his medications. he had seizures. Striking about this patient is if you look at those onset regions, it looks like the default mode network. This frontal parietal network that we describe in intracranial looks like the default mode network. So we have used this patient, Dr. Zavari, as part of our group, has used this and many other intracranial patients to look at the connectivity and say, can we provide what I've talked about, neurophysiological evidence for the default mode network? And both times we've failed. We can't find connectivity to support the existence of the default mode network. And so we've looked at this patient, we've looked at many other patients, and we can't find any significant connectivity. Even this paper looks at the second spectrum, which looks at the sort of ultra-low frequencies to try to mimic what the bold signal gives us, and we still failed to find it. So there's perhaps a node somewhere else that we don't have data from, and there's an increasing amount of data to suggest that this node might be the thalamus. So we need to go to long-term intracranial monitoring at home while patients are on their medications, while patients are living their lives. But how do we accomplish this? Well, you can imagine the to-do list to be able to accomplish this, but some of the main things, just to have a device that you can talk about studying, you've got to have power, which is a big issue, although battery technology is improving in these implantable devices. You've got to have wireless transmission of this data, right? These patients can't live their lives with 100 wires coming out of their scalp. Just the infection rate alone would be unusable, not to mention the inconvenience. Variety of sensing modalities. So this is something we've worked on a lot at Yale. I'll go over in a second. We can't just have EEG. We've got to have metabolites, neurotransmitters, partial pressure of O2, cerebral blood flow. We've got to acquire and store this data, and then we have to come up with effective neuromodulatory therapies. Variety of projects that we have going on: wireless intracranial EEG, working on, the patents are listed here, working on RF conduction to both deliver power and take out data so that you can have a device that does record intracranial EEG that doesn't require battery power. We've done through a couple phases of this, and now we have an animal that's been implanted with a 64-channel wireless intracranial device. So this is being worked on by several other groups as well. But we're hopeful that we can multiply these devices as the technology available grows. And you can power this with a battery or RF power as well. So you can have the options to have either wired or wireless power. If you're going to have a long-term implanted device, it has to be fault tolerant. In other words, you can't just lose 3 electrodes and no longer be able to record, the EEG data that you need. And so we've done a significant amount of work designing these different electrode patterns and electrode grids and strips that develop fault tolerance, so that if you lose even a large number of contacts, you can utilize the existing contacts to try to make up for that. And the algorithm for doing this is actually built in to the device that the electrodes are in. So it doesn't require external connectivity, and this provides you with a reliable electrode array. We've developed a fault-tolerant thin film grid that we've implanted in some rats to look at the loss of multiple contacts, and also try to do wireless transmission of this intracranial data in a fault-tolerant monitoring system in these animals. This is a slide that I borrowed from Dr. Spencer. It's hard to read up here, sorry for the color. It's a cooling and stimulating grid. So another possibility for modulating networks is to cool them. If you cool the brain, you turn it off. We use this in surgery all the time, where we keep a bucket of sterile ice sailing around in case the patient starts to have a seizure in the operating room. It's the fastest way to stop it. If you can cool a grid through a variety of contacts, you can do testing of what happens to the system if you were to remove that particular part of the network while the patient is behaving normally. This is an example of a device that was designed and we used in rats, and we've proven that we've been able to cool the rat brain with this device. You can see it's obviously way too big and has way too much hardware on it at this point in time, but it's a first step. And we've taken the next step, which is looking at how we can cool in the human. This is a human test here during epilepsy surgery. Part of the temporal lobe that's going to be removed as a temporal lobectomy. And we were able to cool. This is the flow. This is the current that's being utilized. This is the temperature measured in a probe that's in the white matter underneath the cortex. Able to cool the brain, but especially the white matter. As you can see, one of the issues we're up against is the brain is very good at regulating itself. So after about 5-10 seconds of this temperature, it starts to warm despite the fact that we're turning up the power on the cooling device. So we have more work to do here. The next thing is to have multimodality. So this is something that's becoming common actually across ICUs, neuro ICUs across the world, where instead of just recording intracranial pressure, we're trying to record a multiple array of things: intracranial pressure, cerebral blood flow, the temperature, the partial pressure of oxygen, intracranial EEG. And we have a scenario set up both in our ICU and in the animal lab to be able to do this type of multimodal monitoring, easy for me to say. But the key is, rather than having 7 devices from 6 different companies, we are designing a device that does it all. We call it the NeuroProbe. We have designed a prototype. It's taken a couple years to get here, but this is just a prototype of a device that's now being tested in animals that's capable of doing cerebral blood flow, ICP, intracranial EEG, as well as 1 or 2 other sensors in a single probe. So you could go back to just making a small burr hole, putting 1 probe into a patient, and you could get all of this variety of data rather than what we do now, which is to put 4 or 5 different devices into the patient's brain. Now that we're understanding this network, I've talked a little bit about in the last patient in the default mode network about the thalamus, and we're getting more and more data that the thalamus is a key node or hub that we really have very little data on, because it's not a place that we commonly put electrodes in an intracranial study. It's not a common place that we put electrodes other than in movement disorder patients who get DBS. But we really need to understand what's going on in the thalamus. We do know from our 7T MRI studies that there's metabolic abnormalities. And then the Sante trial with anterior nucleus DBS is approved in Canada, so we're definitely getting the concept of going there to modify the network in patients with epilepsy, especially temporal lobe epilepsy, which the anterior nucleus is part of the limbic system connectivity. We'll give some evidence for central median nucleus DBS in epilepsy. There's been some reports outside of the US utilizing this deep brain stimulation technique for treating epilepsy. And at Yale, I collaborate a lot with Hal Blumenfeld, who has a large lab that studies consciousness in epilepsy, and he has developed this theory that he has that what seizures do is they change the brainstem arousal, they change the arousal network, and that when you turn off this arousal network, the cortex goes to sleep, if you will. It goes into the slow, that standard slow delta rhythm that we see in seizures. And so in the seizure model in the animals, if you stimulate a seizure by stimulating the hippocampus, you look at the cortex typically goes into this slowing, which you see if you spread this out. You see cortical slowing that we all see very commonly in epilepsy. But if you do CL stimulation, which is a nucleus in the rodent thalamus, which is analogous to the CM, the central median nucleus in the animal, we weren't able to stop this slowing during seizures. And so we weren't able to block their loss of consciousness or freezing or sort of the racine stage that you'll see in animals. But we were able to block it in their post-ictal state. So that if you look at their post-ictal state, they no longer had this slowing in the cortex. So it wasn't a home run, but it showed that there is some ability to affect that slowing and hopefully the arousal network or the network of consciousness. The theory being that even if the animal or the patient were to have a seizure, what if we could keep them from losing consciousness so that you could have a seizure and you could essentially isolate it from the rest of the network that involved arousal, attention, and consciousness. So in the same animal model, we add in the Blumenfeld lab, it's a paper that came out in 2016 with Hal and I collaborated on this paper. If you take the same animal model, now we stimulate in the P&O nucleus, which is one of the arousal system structures in the brainstem, and the CL nucleus in the animal together, that we were in fact able to block this large slowing activity that happens in the cortex, both during the seizure and after the seizure. So stimulation comes on, this big slowing goes away, stimulation goes off, you see the big slowing comes back, the seizure ends, but when the seizure ends, they don't go into the classic slow waves that you see post-ictal. What does this mean behaviorally? Well, if you look at the animal, so if you look at the score, you sort of have normal behavior here, the freezing and rearing that's common, and then the autonomic, and then you can get the different racine classes here. that you see in just watching an animal walk around in a cage. If we look at their baseline, they have normal activity. They have the sham group and a DBS group, so they have a seizure, okay, pre-DBS. You turn the DBS on, and the DBS group goes back to almost baseline, very different from the non-stimulated group. And you can basically make an animal look like they're not seizing if you're just watching them in a cage by using stimulation in these regions in the brainstem and the thalamus. So I'd like to wrap this up by one more patient presentation as we talk about moving forward. I'll go over this briefly given the interest of time, a 32-year-old patient who had multiple malformations of cortical development, a 16-year history of frequent complex partial and much less frequently, luckily, secondary generalized seizures, had been on 10 different medications that had been failed, underwent a complete preoperative evaluation, multifocal malformations of cortical developments. Largest lesions were right frontal, right periventricular region, more than left. Neuropsychiatric evaluation was, again, not lateralizing. And so the patient underwent a survey study, which now we use stereo placement of depth electrodes using the ROSA robot. You can place several depth electrodes. This is just a list of the depth electrodes that the patient had placed for a survey study. And what came out, he had several seizures during his recording period, is that he had broad onset areas. His onset area was a little more focal, but it was very quick as we talked about the spread. Within a second or two, you would see very similar homologous regions on each hemisphere, parietal, posterior temporal regions, which were both where his spikes were as well as his seizure onsets, more so on the right side than the left side. These are the two main depth electrodes at the onset zone, but it was very quick spread across the array. So this is somebody that in the past we would have basically thrown up our hands and say, sorry, we can't really do much in this case. We did a lot of discussion, and with approvals for humanitarian use, we decided that the best place to try to treat this person's epilepsy, and really the only chance that we could think of that would help significantly modify their seizures, because this particular patient has 10 to 20 seizures a month, was through the thalamus. So this particular patient is, as far as we know, talking to the people that use this device, is the first human central median implant using the responsive neurostimulation system. And you can see strips placed over the onset regions in that right parietal posterior temporal region, and the electrode into the central median nucleus of the thalamus to deliver stimulation. And so, as we talked about with the responsive neurostimulation device, we're very hopeful that this will help at least modify significantly his seizures. The surgical implant went fine. Patient's doing well. He's been doing well for several months now. And the recordings that we're starting to get, one of the questions in the debate that we had in our conference was, would you even see a seizure in the thalamus if you recorded from the thalamus? More than a decade ago, we had, for a short period of time at Yale, before I was at Yale, they had collected data from 5 or 6 patients where they did put depth electrodes in the thalamus during their study. Didn't really see much. So the first question that we had was, what kind of a signal will you get from the thalamus? So these are the traces coming in the responsive neurostimulation device. This is the parietal area, which you can see is very active in this particular patient. But there is a signal in the thalamic electrode. And although this is still preliminary data, it's literally happening in almost real time, it's data from only last month that hasn't been fully analyzed yet, turns out, yes, you can pick up seizures in the thalamus. So this is seizure detected, the blue is detection stimulation on, and especially in longer seizures or long detections, you see the seizure develop the slow rhythm in the thalamic electrodes. So the first question we had has been answered. Yes, you get seizures in the thalamus, and you can also get reflections of spikes that are happening in the cortex in the thalamus. So again, we're getting great data as this epilepsy patient lives their life. And we've now turned on the stimulation, and it's going to take several months before we know, but we're very hopeful that this will help at least modify the seizures. Long-term data needs to be shown, but we know at the very least that we're going to have data to help with the epilepsy. We have an abstract at the AES last year and a paper that's coming out that shows that if you're using the recordings from the responsive neurostimulation system, that suggests that within 7 days of a new drug, you can determine whether that drug is going to be effective. So rather than spending 6, 7, 8, 9 months trying to figure out if that drug is going to work, if you look at the recordings, the changes in the detections in the device, within 7 days, you can tell whether that drug is going to be effective or not. A very useful therapy. So where do we need to go? I'll wrap up. New generation of electrodes, multiple bioelectric high-density electrode arrays that are capable of recording from a variety of information, not just EEG. We need wireless and power technologies. They exist, but we need to bring them to neurological devices. We've talked about the data and storage. Wearables are becoming increasing popularity in epilepsy population. We need to have the same connectivity, the same ability to transmit data seamlessly and wirelessly with a personal smart device from things that are implanted into the patient's brain and recording their EEG. And then we need to modulate. We need to be able to treat these patients. This is just an example of a variety of different electrodes, one that we've proposed. This is from the DARPA subnets, which was from the group at Mass General. The Utah array, most people are familiar with, and up there at the top is the Spencer depth electrode, which has been around for a long time. Again, just a close-up of this variety, just to show the theme, that what we need are multiple banks of different types of electrodes that are designed to record from different parts of the network. So that in the end, we need to have bioelectric intracranial studies based on their data that we have, their localizing and pre-op data, fMRI data, et cetera, with the appropriate cortical and subcortical nuclei. Patients spend maybe 5, 7 days in the hospital in a biosensor suite so that you can recover them from the implant surgery, make sure that they're doing well, and then they go home. And they need to have a long-term study at home on living their life on their normal medications. And we need the ability to capture all of this data to be able to modulate the network and do testing as far as what would happen if we stimulated for functional testing in the EMU. We need to be able to do the same testing in these patients wirelessly. And then the analysis of this rich data will create a new decision tree regarding the network of that particular patient's epilepsy and our ability to interact with that epilepsy through a variety of techniques that are utilized to modulate the system. And I'll end with that, and I have way too many people that I could possibly thank. But on this slide, several people who deserve personal thank and recognition, and a variety of labs throughout Yale who've contributed to the variety of work presented today, and my mentor and still director of the epilepsy surgery program, Dr. Dennis Spencer at Yale. Thank you.
Thank you very much. I have a couple of questions. One is about the microdialysis that you have done for years. You mentioned which showed increased glutamate in propagation regions more so than even the seizure focus, if we were to name it as such. These measurements happen during which phase? Interictal, postictal?
Yeah, so a variety of phases. As I pointed out, one of the big weaknesses of that technique is the sampling rate. You're only getting a sample. Even if you have somebody bedside going as fast as you can, you get a sample every few minutes. Most of that data is interictal. So it's very rare that you actually capture a seizure, but some of it, of course, is postictal. But the majority of it is in the interictal period. So the handful of samples during this analysis, that happen right after a seizure, right before a seizure, we'll evaluate it, but there's not enough data to really say anything about whether you see a change immediately before, immediately after a seizure.
So, and when you say propagation region, it is the seizure propagation region, not merely interictal, like not merely the irritative zone.
Correct. So it's utilizing their widespread coverage in their intracranial EEG to determine the propagation nodes, and then looking at the microdialysis in those nodes.
Thank you. Another question has to do with the very definition of a network concept for seizures versus a focus concept. there is no, they are not mutually exclusive, meaning, of course, seizure is a network because it propagates, and it propagates across the same pathways consistently in focal epilepsy. That's one of the hallmarks of focal epilepsy. But there's always a seizure onset zone. Not always. In the vast majority of cases, there is a single seizure onset zone. If I were to play the devil's advocate, you know, some of the evidence you presented for a network concept is bilateral temporal epilepsy cured with unilateral resection. This may be due to the fact that when we monitor the patients and we find bilateral temporal lobe onsets, we are lowering the medications, or maybe there are different thresholds for different areas of the brain to seize, but some of them can be silenced by medications and some not. You know, the other thing is the cognitive deficits in temporal lobe epilepsy is definitely there because of continuous bombarding by the seizure activity. So the devil's advocate argument is that in some temporal lobe epilepsy patients after hippocampectomy, the cognitive deficits improve a year later. You know, verbal memory and others, you know, after focal resection. So the whole point is epilepsy is definitely a network problem. And this is probably what happens during the latency phase after an initial, the classic story of epilepsy, initial insult, latency, and then spontaneous recurrent seizures. Probably what happens during latency is just amplification within the epileptic network, you know, to facilitate the origin and propagation. But it doesn't totally exclude the focus concept.
Correct. Yeah. No, I don't think that the goal is to exclude the concept of focal onset. What we're saying is that it's even in epilepsy that has a focal onset, there's still a broadly distributed network that onset is playing a role in. And I would argue that the reason that you can get some cure rates with the bitemporal patients is that you're taking out a big node, okay, in the network. And that what happens in this variety of patients and their outcomes is how well connected or how robust the connectivity is in that particular node. But the fact that you don't cure all the patients means that there's still epileptogenesis going on in things that you did not take out. There's still a network that you left behind. And that many times that network continues in what I'm going to describe as an epileptogenic process, epileptogenesis, that we don't really have information about, to be honest with you. Hopefully our long-term implants will give us some information about this. And that over time, that network then goes on to develop the connectivity required for it to seize without the piece that you took out, which is why you see the much higher incidence of long-term recurrence in those patients. And again, for the neuropsych data, I would argue that the reason that the patients get better is because there is still a network out there that's connected, and when you take the seizures out of the network, that network then goes on to improve. It no longer has this process of bombardment, I think, which is a good thing, where you're sort of flooding that network with information that's not useful.
Yeah, makes sense. Thank you very much. Yeah.
I have two quick questions. First is about that the probe. I think it's neuroprobe, and so it's kind of hard for me to imagine with like one probe they like monitor different things. Is that they have different contacts?
Correct. Yeah, I didn't have time to show some of the close-ups, but there's if you zoom in on the tip of that probe, there's a bunch of different sort of ports and contacts in the probe that are designed to do a specific thing.
And for that, the intracranial EEG, I'm not sure how the intracranial EEG do for that. Do you do for just regular patients or for you particular concern for seizures? In that case, then you have to be on the seizure onset zone. I just don't know how.
So right now, actually, the patient population that utilizes this multimodal monitoring the most is actually the TBI, the severe TBI and subarachnoid hemorrhage patients in the neuro ICU. So that the probe right now is designed to be utilized in those patients, to be honest with you. But our ultimate goal is to get a device that does all of these things, that can give you the moment-by-moment glutamate levels, the different neurotransmitters that you can utilize in epilepsy patients. But right now, that's the patient population. So it's being designed almost like an ICP monitor would be. So you can put it in through a single small burr hole.
Yeah. Another is about that like a macular dialysis, and just intuitively, I would imagine like the seizure onset zones, like the glutamate level will be higher than propagation. Can you explain why it is kind of
Yeah,
opposite?
so it's a good question. It surprised us, and we've actually have animal models now based on glutamate. So we've created an animal model at Yale that actually looks like it's a great temporal lobe epilepsy model where we block glutamate reuptake in the entorhinal cortex of one hemisphere in the rat, and about 85% of those rats will develop epilepsy, and they develop temporal lobe epilepsy. I'm studying them in my lab now using lots of intracranial electrodes, looking single unit to EEG data and trying to look at how their seizures propagate and how the network changes with time. But what we think happens is if you go back to sort of the classic description of medial temporal sclerosis, we think that the network there is just completely burnt out.
Okay.
And that you see all the cell death, that just the connections are gone in the particular onset zone. But you kind of have, I don't want to necessarily call it normal, but if you go to the nodes, the propagated nodes, you have a disturbed sort of sick network, if you will, but the connectivity is still preserved. And that's why we think actually you're seeing even higher concentration of glutamate at that nodes, is because that network's still intact, if you will, but it's disturbed.
Okay.
Great. All right, well, thank you.